We do have a lot of folks already joined. Thank you, everyone, for joining us today. We're very excited to have Dr. Williamson speak on blood pressure lowering failure to implement a key component of the public health goal of reducing risk for physical and cognitive disability. Dr. Jeff Williamson is a professor of internal medicine and epidemiology and internationally known geriatrician and clinical trialist. He serves as co-leader of the Wake Forest Alzheimer's Disease Research Center Administrative Core and is the clinical core principal investigator for the university's Claude D. Older Americans Independent Center. Dr. Williamson received his MD from the Medical College of Georgia, a master's degree in clinical epidemiology from the Johns Hopkins University School of Hygiene and Public Health, and completed his fellowship in geriatric medicine at Johns Hopkins. Dr. Williamson's primary research interests are in understanding relationships between chronic diseases such as hypertension and diabetes in the maintenance of cognitive and physical function in aging adults, and in developing research methods for including older persons in clinical trials. Dr. Williamson is currently serving on the leadership team for nationwide research studies funded by the National Institutes of Health. These include the Sprint Mind, Preventable, and Dementia Care studies, and he co-leads the Alzheimer's Association CDC BOLD initiative on dementia prevention in public health systems. Altogether, his NIH research studies have involved more than 40,000 adults over age 65 and 15,000 persons over age 75. So, Dr. Williamson, we're thrilled to have you. We'll let you take it away.
Sarah, thank you again. I'm glad to be here. I think my mother wrote that initial introduction, but so a short one would have been fine too. I need to tell my assistant that next time. So, no, I'm glad to do this. It's a joy for me. I was just telling Michael Wolf, thank you for the invitation, number one, and I always love talking about this topic, of course. But it's a warning topic too. It's a long title. It looks like a Puritan monograph, sort of, with all these words in the title. But I think one of the things that Sprint is beginning to reveal is how poorly we implement research discovery that even has a good bit of evidence behind it. So we'll touch on that at the end and hopefully have time for a good discussion about all this. And I'm working now to try to make sure that there we go. So I have really these disclosures to make. Most of them are federal funding things. I do have some funding from the Alzheimer's Association there in Chicago, and from our institution has some funding from Biogen as well. I really want to start I spend my clinical time mainly as a primary care geriatrician, also seeing people with memory impairment, especially early in the course of their disease. But this is a couple that I saw a couple of years ago now. They were new to my practice. As you'll see down below, I actually took care of their parents at one point. I've been at Wake Forest long enough to do that now. But they're in their late 60s, early 70s. Mom and granddad retired. And like many retired people, they're beginning to turn toward, this concept of how can we keep from happening what happened maybe to some of our parents, but what health promotion practices can we put in place? So they're exercising and dieting and learning about fitness, and they have the typical chronic diseases for this age group: some blood pressure medications, mild hyperglycemia. But her mom, as I mentioned, was previous my patient. She had lost her memory beginning in her early 70s, and then went on to develop dementia. And his dad was institutionalized due to heart failure and a stroke, and his dad also had mild cognitive impairment. So they really want to reduce their risk for experiencing these earlier than, and they want to delay this as long as possible and hopefully completely prevent it. You can see their blood pressures there at my office visit, and really they said each of them, they kind of switched over to a geriatrician now. But they said their prior doctor had said their blood pressures were fine, and the doctor had been shown the Sprint results. One of them's children was a Sprint worker, Sprint colleague, and so and their doctor said, "I'm aware of the Sprint results, but I'm not really convinced that it's that important." So that's really going to be the focus of our talk. I do want to spend probably a good bit of this time just reviewing the evidence, because I still find that, we're all so busy now. You don't get to hear the perspective of the writer of a paper even though this work has been out now for between 4 and 8 years, depending on which paper you're referring to. So the first is just starting with an overall philosophical slide that almost all of us, especially those of us involved in Claude Pepper work, I've used this slide ever since I was a fellow, but it really sums up what we do in clinical care and geriatrics and gerontology and research. And that is, we're trying to expand active life expectancy. We're trying to push that orange line onto the blue line and make that space in between them as small as possible. And this graph really was the thing that spurred me to think about being a geriatric fellow when I sat down many years ago with my initial mentor, Linda Freed, and we were talking about the work of Jim Fries. And so this compression of disability, so to speak, into the shortest period of life is really all the work of the Pepper Centers. It's the work of many of us on these calls. It's really the work of the Alzheimer Centers too. Now, when we talk about people becoming disabled, this work is still as fresh today as it was 25 years ago. But because most of the hospitalizations that end up resulting in disability are listed here, and you see the ones in red are really complications of hypertension, stroke, heart failure, coronary heart disease, and then now, based on work that I'm going to show you, at least on outpatient and maybe not inpatient hospitalizations, dementia, all types of dementia are not all types, but most of the most common types of dementia are related to hypertension. They're a complication of this condition. And this condition is very prevalent. So this slide taken from NHANES, which is again no different today than it was a few years ago, simply shows every time I see it, it's a stark reminder of the prevalence of this condition, hypertension. By the time people are 50 years old, half of our population has elevated blood pressure. And by the time people are over the age of 75, you can see 80% of people are more or have some form of hypertension. So this could be seen as bad, but it's a great opportunity for us who are practicing prevention to say, if we can find a link, if there's a link between this very prevalent condition and disabling diseases, then we have a huge public health opportunity to make a big difference, especially in healthy older people. So this was really, at least in Sprint, I was not the only geriatrician. We had quite a few geriatricians that were able to join into Sprint, and I think influence this trial, as you'll see, a great deal to not simply look at cardiovascular outcomes or renal outcomes, but to look at outcomes that are important to older people. It was a very large trial. The initial results, as I said, were published now almost 8 years ago, and the cognitive results were published about 4 years ago now, a little over 4 years ago. But you can see that there are almost 10,000 people in Sprint. Now, we excluded people who had prevalent stroke and diabetes because there were trials going on testing blood pressure goals already, and I listed them there: Sprint, SPSS, and SPS3 and Accord. Then CHF patients were excluded who had a significant CHF because we already knew that their blood pressure needed to be controlled very well. And then we included people with very low renal dysfunction or significant orthostasis. But otherwise, everyone else was able to participate in Sprint. And the co-primary outcomes were listed here on the right: all-cause mortality, cardiovascular disease, kidney disease, and then mild cognitive impairment and dementia. And as some of you have heard me say, I wish that now we had included these as a composite outcome like the cardiovascular disease people do. But we separated the outcomes into incident dementia and incident MCI, and otherwise I'd be talking to you from the French Riviera now, perhaps. But so the very important thing, though, is that I really, a major message from this talk I want you to get is that large simple trials, and that's really what Sprint was, a large simple trial in many ways. They can include outcomes that are important to older people, and not simply mortality outcomes or let's say the big cardiovascular outcomes that many cardiovascular trials have had. And this has been built on the experience of many people, leaders in the CHS, the cardiovascular health study, and other great studies, Eric, et cetera, have shown that you can train different sites to assess outcomes that are important to older people. So in this trial, not only did we have the ability to train ascertainment of cognition, but we trained ascertainment of gait speed using a 4-meter strip of paper, not a strip of paper, but a 4-meter sort of walking strip that all sites had. We assessed frailty status using the Rockwood method from data we collected. Depression, falls were assessed using the electronic health records, as well as individual interviews, orthostatic hypotension, hospitalizations, and nursing home placement. So Sprint had a lot of outcomes that were very important to older people, as well as the traditional large trial outcomes. And Sprint was really to date one of the most successful trials in enrolling older people. Almost 1/3 of the cohort was over 75 years old. We were just talking today on an earlier call, the Pepper Centers, about how few older people have been really participated in trials of drugs that are commonly being used for weight loss now. And so many people are prescribing these drugs, kind of flying on instruments, so to speak, in older people. But Sprint, there was a special funding to enroll older people, and we were very successful in doing that. Also, Sprint had a very strong target to be diverse in terms of socioeconomic and race and culture. And you can see there that almost 1/3 of participants were African American and over 10% were Hispanic. And the interesting thing I always emphasize in this talk is that the Sprint baseline blood pressure, you see that in the 3rd red circle, was actually below the guideline at that point when we started. The guideline said a systolic blood pressure of 140 or below was the controlled blood pressure. And so people came into Sprint with a mean blood pressure control of 139.7. So that's the initial population we had. And actually, for the people over the age of 75, these were not pristinely healthy people. 1/3 of the people over the age of 75 had a gait speed of less than 0.8 meters per second, assessed in all 100 clinics using that walker, that metric that I told you about. Using the Rockwood Frailty Index, you can see the average frailty score there. And actually, about 1/3 of individuals had a score of greater than 0.21, which is consistent with frailty, ambulatory frailty, in Sprint. And then we had as you've already seen, a very diverse population, but these people also didn't have a pristinely healthy brains. The mean MoCA score was 22 at baseline. So that tells you the population we're dealing with, but it again provides a tremendous opportunity for those of us who care for older people. We see many older people who are reasonably healthy and ambulatory, but who are on the cusp of maybe a stroke, maybe heart failure, maybe memory impairment that will push them into disability. And so we need interventions that will be effective at doing that. This doesn't negate at all the fact that many of us take care of people who are very frail and have a short life expectancy. And we need to practice the art of medicine and not necessarily apply these findings to all people. What I always tell people in the office is that, especially reasonably healthy and ambulatory people, I want to prevent you from becoming disabled from cognitive or physical problems. And let's start with trying to get you into a good blood pressure range. But if we have a problem, we can always back off. So, and this is what we achieved in Sprint. Again, this slide is not very commonly shown, but I think to this aging audience, I want you to know that for frail individuals in the intensive group, the blood pressure achieved, the mean blood pressure was 124 versus 121.5 for people who were fit and in the older group. And you can see the difference there in the standard group as well. Whenever you start providing medications for free at no cost, you lower people's blood pressure even in the standard group, and that's really what we see here again in this clinical trial. by the way, you can see a little bit of effect on diastolic blood pressure there as well, but not as great. Again, these are old news, but just a reminder that both the primary outcome, the composite cardiovascular disease outcome, I'll show you the components in a moment, as well as death from any cause, were significantly lower in the intensive treated group, with a number needed to treat of 61 for the primary outcome and 90 for the mortality outcome. And again, some of you have heard me give this talk before, but very rarely do you see a clinical trial that impacts positively both the primary outcome and total mortality. So this is one of those cases where the intervention of blood pressure lowering in this population is extremely powerful. This slide simply just carves out those individuals who were over the age of 75. I will say, as a geriatrician, when we started Sprint, I thought that we would not find the same result in the 75. It would be much worse for them, or it would be not much worse. It wouldn't be as good for them, I should say. But here you see that for the primary outcome and for all-cause mortality, the effect was really the same. Actually, the number needed to treat was smaller because there's so many more events in older people. But the NNT was 28 for the primary outcome and 41 for all-cause mortality. And this was with only 3.5 years of blood pressure therapy. So it doesn't take a long time for this effect. In fact, you can see the lines began to really separate at 2 years. And so really when I'm talking to students, if I don't worry too much about blood pressure control in people who I expect their life expectancy is less than 2 years. But if I have someone who's ambulatory and I think their life expectancy is greater than 2 years and they're in reasonably good health, I say, let's try to get that blood pressure controlled so that we can prevent some of these disabling events, cardiovascular-wise and cognitive-wise. This just is a breakdown of all the components of the primary outcome, and you can see them there. I really don't want to spend time there, but because you can look this up. But all the primary outcome components were affected except for non-MI acute coronary syndrome. Otherwise, significant or not. I can't use the word significant because these are broken down, but substantial reductions in event rates. The gait speed also, here we start to get into some of the geriatric and some of the aging outcomes. And you can see that the rate was the same regardless of gait speed. There was a 35% reduction whether the gait speed was greater than 0.8 meters per second or 0.8 meters per second or less. And so, and that was a harbinger for the next slide here I'm showing you, which shows you that whether people were fit or frail or in between, they also had a benefit. The curve on the left-hand side looks kind of funky because there just aren't many event rates, no matter what age, in people who are designated as fit. They have a very low frailty score, but we had a few, and it had a very impressive hazard ratio. But there's actually no interaction between these groups, just due to the size of the groups. But you can see that whether someone is fit, frail, or in between, they benefited from the intensive blood pressure lowering in Sprint. Of course, always we're in geriatric world, we're in gerontology world, we're concerned about falls, and there was no increased fall risk in this group. There was actually no increased risk in the serious adverse events between the groups. Some groups reported more syncope, but otherwise, and there was a little bit more acute kidney injury in the intensive group. Because we hypothesized, most of us in Sprint, that a lot more diuretic use was in that group, in the intensive group, and these people lived a little bit closer to dehydration than people not on diuretics. And so, but there was actually no difference in incident dialysis in the groups whatsoever, even after prolonged 8-year follow-up. Then turning to the cognitive outcomes, this is the main table from the JAMA paper in 2019. And the thing to note here is that the hazard reduction, so about a 15 to 20% reduction, whether the outcome was probable dementia, mild cognitive impairment, or the composite of the two. However, only the mild cognitive impairment and the composite were statistically significant. That's why you saw the headline of the paper say this didn't prevent dementia, because that was our pre-specified primary outcome. Again, if we could relive our life, we'd do many things over, and I would have pre-specified the primary outcome to be the composite of MCI and dementia, and then we would have had a better title to this page. But the editors were kind to work with us, and so you can see here that the rate of probable dementia was about half the rate of MCI, and that meant the number of cases were lower, and so the p-value was 0.10 rather than significant. I think this is a good thing for human beings. It's good that it takes longer to develop dementia. And so we've continued to follow these people up, even though they've been off medicine now for 8 years. We just finished out our last follow-up call on December the 31st, and we'll be reporting whether or not there's a legacy effect of blood pressure on dementia sometime this summer. So keep your eyes peeled out for that. The study also included a radiologic evaluation, and here I'm simply showing that there was more a smaller amount of white matter accumulation in the brains of people who were in the intensive blood pressure lowering arm than those who were in the standard arm. And that's all this shows. So this shows a possible mechanism that there is less vascular injury going on, not surprisingly, in people who have their blood pressure better controlled. Interesting, we also found that blood flow was actually increased to all areas of the brain, people who had a lower, who were in the intensive group. You know, again, many of us hypothesized that blood flow would be lower with lower blood pressure, but it was actually higher. And this also provides some mechanistic clues that we've been working on as well. The last slide here about results before we turn to maybe the impact of this is, and I really probably have only maybe 5 or 10 minutes, and then we can have a discussion, a lot of talk if you want about this. I'd like to hear your own thoughts. But this slide is from a paper that's just published by Adam Bress and Dr. Ghazi and colleagues out at Utah, taking the SPRINT data and just looking at a baseline probability of someone developing MCI or dementia, and then looking at what the blood pressure the impact of blood pressure on preserving cognition was. So going from left to right on the bottom is the probability, the predicted risk of developing probable dementia or MCI based on baseline characteristics. And then the cone at the top just shows what was the likelihood of achieving cognitive benefit. And so you can actually see this is an important finding. It's exploratory. It's not a clinical trial finding because it's a post hoc analysis, but it's an important finding to show that people who were the closest to developing MCI and dementia had the most benefit from better blood pressure control. So this gives me some encouragement to do this in my own clinic for people that I'm concerned about. You know, there are lots of drugs, well, not lots, there's one, but being, you know, approved for treatment of early Alzheimer's disease, and they're expensive, but blood pressure lowering is a proven way to prevent MCI and dementia. And it's really 95% of the blood pressure medicines in SPRINT were generic. And so it's a very equitable, far-reaching way to achieve an impact in this area that disables so many people. The other thing I like to point out about SPRINT is that there's a lot of talk about the importance of midlife blood pressure control, and it is truly important. You get the biggest return on the investment for lowering blood pressure in midlife. But SPRINT also showed that just like it is for smoking, I always tell patients it's never too late to stop smoking. Here in North Carolina, we still have to say that. But it's never too late to lower your blood pressure. SPRINT had benefits you can see on this trial all the way into the 80s. So blood pressure lowering for reasonably healthy ambulatory people was beneficial. It didn't increase falls. It didn't increase SAEs, even for people well into their 80s. And so it's great to be able to give people hope that there's something you can do now if you're a person whose blood pressure isn't controlled, at least into the 120s. Other data sets have shown this same result. This is data from a colleague of mine, Ruth Peters, in Australia, taking the other large blood pressure trials, Advance. I live in Advance, North Carolina, so we always say Advance, but it's really Advance. So Advance trial, HiVet, Progress, SHEP, SISTURE. Ruth and colleagues combined all that data, did a logistic regression, and you can see the result on the far right blue block there that really treatment was favored for reducing loss of cognition and dementia in the combination of these trials, many of them which didn't have as much of a rigorous ascertainment of the outcome as did SPRINT, but did have some form of cognitive assessment that they defined as dementia. All right, so I just want to spend the last few minutes here talking about, okay, we've got this great evidence, but does evidence produce better care? And this was the theme of the meeting that Mike and I were at in Chicago, in Charlotte, not Chicago, both CHs, but back in the fall when I gave this initial talk. And so one of the things you see interesting here is that SPRINT was published in 2015, and yet NHANES shows that blood pressure control actually got worse after the publication of this really amazing trial that invested many millions of taxpayer dollars. And so, what's the reason for that? And there's lots of reasons. One blame actually placed was the blood pressure guidelines that came out just before the ones in 2017 that actually raised the blood pressure goals for older people to 150. So the consuming public says if experts aren't even sure what the best blood pressure control is, why should I be worried about it? So that's probably a big explanation. Those blood pressure guidelines that came out really reduced the incentive for people, for patients and providers to control blood pressure. And that effect was long-reaching, as you can see here, well into 2018. Even blood pressure control with patients on hypertension medicines, as you see in chart B there, was reduced. So that's a very unfortunate finding. The other thing that even speaks more to this is a slide that shows what happened. So what happened to people, especially in terms of mortality, after we stopped SPRINT, but we continued to follow them in an observational way using electronic health record data. And so the two dotted lines are the blood pressure, they're the blood pressure differences between the two groups during the trial. And you can see that the trial stopped sort of a mean after two and a half years. Then we started tapering people off in the light blue column there. And as we began to taper people off, the mortality curves began to come together, and we began to return people back to their primary care physicians who were always aware that their patient was in SPRINT. And then during this observational phase, over the next 5 years, you can see that the mortality curves slowly and steadily began to superimpose until they finally superimposed in year 9. So the gains from blood pressure treatment aggressiveness were lost. And if you look at the blood pressure arms in these trials, the blood pressures that we could detect began to also become synonymous. And it wasn't that the higher people were coming to the lower, it was that the lower people were no longer being treated as aggressively. And pretty soon they were superimposed on one another. So blood pressure blood pressure treatment doesn't seem to have a very long legacy effect, and it needs to keep going in order for it to have a long effect. Finally, my last slide, I believe, is a slide that is taken from our clinics here in the sort of the Wake Forest atrium market. And really, we just took all accountable care affiliated patients over of any age who were diagnosed with hypertension, and we looked at their control rates by clinic. And you can see the control rates range from 10%, only some clinics had only 10% of their people controlled, and the best clinics had only 50% of their people controlled. And this was in 2022, well after the Sprint results were published. And then it's in the health system that really was the coordinating center for Sprint. And so basically what we did here was we looked at the last reading that someone had in 2022 where they didn't have another primary care visit. And many of these readings actually happen outside of the primary care clinic, but they're the readings that accountable care organizations use to actually pay the health system for good blood pressure control. So if someone has a toothache and their blood pressure is probably high, and they go in on November the 30th to get their toothache taken care of, and their blood pressure is high, and that's the final reading. Well, that's the one that's used to pay your health system for good blood pressure control or not. So lots of opportunities here to help improve blood pressure control and the measurement of blood pressure. And this is not my area, although as I've talked to Michael, I'm trying to learn a lot about it, and because I certainly want my own research to be useful to people and not just sit there on a journal bookshelf. Another important opportunity we have is we've known for a number of years. When I first trained, we thought combination therapy was not good, and it was because there was a lot of financial disincentives for patients. Now there are combination pills that are very inexpensive, and we've known for a while that people who take combination treatments have a much better blood pressure control than those who take individual components. And we like to use individual components sometimes as clinicians. We like to tinker with this component or that component. But we've known for many years that blood pressure control is much better if you can use combination pills. So we just looked in our own health system here. People who have a diagnosis of hypertension, 7% were on no medicines. 26% were on one. And by the way, in Sprint, I didn't have this slide, but Sprint showed that on average, to have intensive blood pressure control, it takes 3 medications. And I tell all my patients that let's expect you're going to have eventually 3 medications. If we want to do your blood pressure control correctly and prevent a stroke or heart attack or dementia, or give ourselves the best shot at preventing it, then we're going to have to sometimes go to 3 medications on average. But even those people that were treated in the last row there, you see that almost 25% were on 2 classes, only 2 classes, but even then it wasn't a combination pill where it could have been. So here are some opportunities for us. Make sure that people get a referral if they have a high blood pressure, referral back to primary care if they have a high blood pressure in a subspecialty clinic, and make sure that people who have a high blood pressure at in your clinic have another referral back to yourself if you're a primary care doctor before the end of the year to get that blood pressure under control. So in summary, 3 main points. 1, large clinical trials can include older people, the kind of people we're interested in, and it can include the outcomes that are really important for the older people that we care so much for. It can include outcomes beyond mortality and even disease-based outcomes. Of course, we see that intensive blood pressure control does reduce the risk for disabling acute and chronic conditions such as heart failure, stroke, MI, and the combined incidence of MCI and dementia, even in older adults. And even that persons with early or increased risk for memory impairment appear to benefit from intensive blood pressure control at a lot lower cost than some of the current agents. But we also see that clinical trial evidence is not enough. Blood pressure control is actually worsened despite improved evidence. And so there's a critical need to demonstrate effective implementation strategies in pragmatic settings. Frankly, today, I think we've all seen it. There seems to be less trust in scientific evidence by people from all walks of life. And so we need to work on ways to restore that. And because so much of the gains we've made in the last 50 years are based on that kind of trust. So that's really the end of my talk. I think we have a good amount of time, Michael, for discussion or whatever you'd like to do, or letting people go have lunch.
Well, you already got a hand up with Jeff. The other Jeff.
Yep. Yeah. Right. So we're Jeff W. and I are on another committee together, and he's the OG Jeff, and I'm new Jeff. So I was going to ask, can you go back to the slide showing the EHR versus sprint measured blood pressures?
Yeah.
It was maybe 4 or 5 slides back. Because yeah, I mean, from an implementation standpoint, I think Sprint came under a lot of criticism for the way blood pressure was measured, because it was measured using, this automated cuff. Persons in a quiet room by themselves for 5 minutes. The cuff takes 3 readings. You take, I think it was the average of those readings. And it's when I heard about Sprint and when I read all the results for Sprint, I was very worried about the lack of real world applicability. And I don't deny or argue with it all that the findings of Sprint are scientifically correct. And that probably is the right way to measure blood pressure. But from a pragmatic, implementable standpoint, I worry that this graph shows that the way we actually measure blood pressure, capture blood pressure in the real world, is different from how it was measured in Sprint. And I think that disconnect has led to some barrier to implementation of the results.
I think you're right, spot on. There's a couple facets to this diamond. First of all, I will say that I've had a number of bullet holes put in me by going to clinics and saying, here's how you should measure blood pressure. And they're all, until I give the actual talk, they're all in favor of good blood pressure measurement until they see how that might affect their current workflow and their RVUs. It's not the workflow, it's the RVUs. Okay. So I think, Jeff, because of the prevalence of this, there are many other health conditions that we take time to take care of, but we're paid to do it. And so to me, this is a pay problem as much as it is a workflow problem. I really think that we're not really incentivized as providers to take care of this highly prevalent, highly impactful public health problem. And until that happens, I don't think we're going to see really good implementation in the clinic. And that, by the way, that doesn't excuse, even in my own clinic, I still see people, it's wintertime here, not like Chicago, and it's not even a world winter here. But, I still see blood pressures taken through sweaters and coats and all kinds of stuff. And even when they're just taking it one time. And there are some ways that we're now pragmatically doing this in our clinic, where if the blood pressure is normal, you don't need to take it 3 times. But if they get a high reading, we do make sure that the blood pressure is taken according to standard, just as much as we make sure that when someone is sent to the lab, that we, make sure we have a sterile stick. And it takes time to do that, to get those lab values. But this is more actionable, I think, than almost any other lab test. So I grant you all the things that you just said, but I think that we really need to work on our system and our payer system if we're going to see this important risk factor taken care of. Are you still there?
Yep.
I hope I didn't.
No, Jeff. I think Jeff just went dark a little bit, but that's
no. I agree with all that, and I think for what it's worth, like whenever I get whenever I'm on a committee that's unfortunate enough to have me as a member, the 2 things I'm always saying for adults, like the 2 things we could do that have the biggest public health benefit are getting smokers to stop and getting blood pressure under control. So I totally agree. We need to do a better job of blood pressure, and I think we're using more combination meds. And Steve Purcell here at Northwestern is doing a lot of work to move the needle on blood pressure control here. But yeah, curious to what, I think there was something in the chat I saw, and then what questions that other people had.
I think Dr. Vassar, you got your hand up first.
I see my friend Bob Vassar that I've let down for like 5 years now. He's emailed me about a question but anyway, Bob, good to see you.
You too, Jeff. Congratulations. And this was a great talk. I think Sprint Mind is transformational, and thank you for getting the word out about blood pressure control and how it can affect dementia. So I'm as you are, I'm sure, interested in the interconnection between blood pressure and Alzheimer's disease. And are we looking at two different diseases, where blood pressure is leading to its own cognitive sequelae, where and Alzheimer's is a separate parallel disease going on, and the outcome is a sum of both of them? Or maybe perhaps more interestingly, are they connected mechanistically, and could blood pressure affect the pathophysiology of Alzheimer's and maybe predispose to it? I'd like to hear some of your thoughts about that.
Yeah, great question. You and I have crossed paths in different things, and I think about blood pressure and Alzheimer's disease a lot of times. Like I think about it like I think of blood pressure and heart failure, blood pressure and diabetes. I think there are some independent factors, but I do think that this is there is some interaction between the pathology that's associated with blood pressure, with Alzheimer's disease, and the pathology associated with blood pressure. And I just believe, I hope I live long enough to say that there's going to be a lot of work maybe coming from your lab and others that just show a more strong link. I'm very interested, we can all talk offline, any of us, about combining blood pressure with some of these newer agents that are coming out. Okay, blood pressure lowering, we do this in so many other diseases. We combine 2 different treatments for diabetes, 2 different treatments for heart failure. We need to start thinking about that in that realm with dementia and Alzheimer's disease. So great question. I believe the blood-brain barrier, Bob, as I think you probably do too, is intricately intertwined with this question of vascular risk factors and Alzheimer's risk factors.
Absolutely. And, I was just going to add that one of my favorite genes, ACE, is a bona fide Alzheimer's disease risk factor gene. And, we're in our lab very interested in what the mechanism of that intersection is with blood pressure control and AD. But I think that there's so much more work to be done in this area. And hopefully, your lab, my lab, and other people will be drawn into it more and figure out what these connections are. So thanks so much.
2 additional comments, and I see Rashida has a question. One, for me, it's really kind of funny that for me, I'm actually not a hypertension expert, and I'm not a dementia expert. I'm not an Alzheimer's expert. I'm more of a clinical trial expert. So, and a geriatrician. So, I really love to work with people who are experts in those areas, because I always learn a lot from them. The other thing is, I didn't show this slide, and I think, Bob, you and I may have talked about this, but there is some secondary work in Sprint that has looked at, okay, what about particular classes of drugs, and did they have a greater effect? What we found is that, and this public paper has also been published by Adam Bress. I'm on that paper, but that the blood pressure lowering trumped everything. If you're in the intensive group, it was great no matter what got used. But it seemed that for the standard group, it did matter which agents people used. And so I won't go into all that now, but you can look up that paper. But I know we've had some discussions about that. And I think there's still a lot more work to be done in that area as well. Okay?
Absolutely.
Rashida?
Hey, good afternoon. I do geriatric nephrology, and one of the things that crossed my mind when I was listening to your presentation was, yeah, my patients who I follow, like for conservative management, who's really advanced kidney disease and choosing not to do dialysis, I have a very liberal blood pressure goal, and it makes me wonder if that should be different. But I recognize these were not the people enrolled in Sprint. And so I'm just thinking, I'd love to know from your impression, what do we think about studying blood pressure lowering in people with life-limited illness, or how would you extrapolate any of these findings to that population?
I love this question, Rashida. I'm so glad you asked it. So this is a time for a geriatrician to wax eloquent about these kinds of things. So I use function as a vital sign in my practice. So if someone is cognitively and physically functioning, they're walking and remembering, well, then let's just take renal disease. Most people die from renal disease because of strokes, right? Or heart attacks, correct? I think that's correct. I'm not a nephrologist, but I have some friends who are. And so
yes, cardiovascular.
yeah. And so really, if they're still walking and remembering and making good memories, I try to do whatever I can to try to keep that going for them. But then if they become disabled, if they really do have, for my patients who have dementia and my patients who have dementia and disability, and they're really not looking at a long life expectancy, or there's not much functional gain from an intensive blood pressure control, I start liberalizing that blood pressure. Okay, because there are more things that I can have them do with their money than take pills. Okay, that's sort of how, I mean, that's a sort of a philosopher geriatrician look at things. But and there are other geriatricians on this call that might answer differently. But that's sort of how I do it. That's, by the way, let me just say, that's how I'm answered. You know, I've had my share of critics in the geriatric world because of Sprint, believe me. But but I also, you know, Sprint was not designed to test people in nursing homes or people with dementia. We care for those people, but it would be the same as saying we shouldn't study the effect of cholesterol lowering on healthy people if we can't include people who have an ejection fraction of 18%. Okay, so your question kind of abuts on all that, but that's sort of how I think about that. And if I still want to prevent cardiovascular and cognitive endpoints in a person, then I still treat their blood pressure. Is that okay?
Absolutely. Yeah.
There's a question in the chat, and then there's another hand raised.
Okay.
Are there any policy recommendations to support treatment intensification?
Well, there are the blood pressure guidelines. You know, guidelines are great, and you know, they're not law, but and we're working on a new set of guidelines. Some people are, but the blood pressure guidelines currently say that for healthy ambulatory older people, a blood pressure of below 130, actually all people, a blood pressure below 130 is the initial starting point. And so the problem we've had, just to be honest among all of us friends here, is that HEDIS guidelines have been hesitant to put that in, and we have two medical societies, the American College of Physicians and the American Academy of Family Physicians, that will not adhere to those guidelines. And so that creates confusion for patients. And so, but the data that I showed you, that last slide on control, was the clinic. We took 140. I didn't even mention that. And that was not 130. That was 140. We have some clinics that, these are all primary care clinics, that they're only 10% of their people are controlled to 140. So I'll grant them the 140. But the bottom line is yes, there are guidelines that say, published guidelines by the American Heart Association, the American College of Cardiology, adopted by the American Geriatric Society, and many other medical societies. It's just those two have not adopted it yet, that say 130 is the guideline. Maybe, Sarah, right before I answer this next question, I always want to emphasize to people, that's not a law. I talk to my patients again about, let's see how you feel. Most people don't feel any different at 120 than they do at 140. And so I said, let's try to get you from 140 into the 120s. And if you don't feel well, if you feel this is really, then we'll back off some. But I'm telling you, 8 out of 10 times they don't feel any different, and yet I've lowered their risk for stroke, heart attack, dementia a lot. Okay, next question. Sarah, you can see the list better than I can.
Yeah, sure. Michaela Raji.
Yes, thank you for this interesting talk, a good review. I'm from University of Texas Medical Branch, Galveston Island. It's a little cold here today. It's in the 60s, so I have to put on my sweater. Anyway, my question really is, I'm looking at this slide, why we cannot turn evidence into practice. And one thing I find in my practice is the big role of social determinants of health. The kind of thing we all know here, the neighborhood, the income, the transportation, food insecurity. I mean, the usual thing we all know about that have incredible impact on health beyond medical care. So I think it is very important to oh, I don't have my slide on. Anyway, to kind of find a way of incorporating that in a more pragmatic way. That's a comment, but my question is also I was looking at the demographic here, the lack of inclusion of Asians,
Yes.
specifically, and as you know, it's one of the fastest rising demographic, at least in anyway, worldwide, but also in North America, and I'm referring to Asia, India, China, as well as people living here. So the extent to which that applies to them in terms of both geriatric focused outcomes as well as classic medical outcomes. But my biggest comment here is how do we factor in the social determinants of health, which tend to play more role in racial and ethnic minorities, because it's usually a proxy for adverse social determinant of health factors. Thank you.
Michaela, tell me your first name. How do you
Michaela, that's how you said it. You said it right. You must have
good.
been practicing. Last name is Raji. Yes, thank you.
I think this is a critically important question. There is some hope here that I want to point out. As I pointed out at the beginning, Sprint had a very diverse population, and blood pressure control did not differ by race or culture in Sprint. So I didn't show those slides. And the medications were generic. So we need to do a better job of overcoming the social determinants of health barriers, even beyond, including cost. We showed also that if you provide the medicine for people, they control their blood pressure, right, at a reasonable rate. Now that's a whole different discussion. I don't want to get into that, but I am saying that Sprint gives a lot of hope to say that we can impact the cognitive health, of cardiovascular health of a diverse group of people through blood pressure lowering. I didn't include the Asian group in here. That we had about 7% Asian, but to give you a better, there's a study that was just presented at AHA that's going to be coming out called the China Rural Health Study that duplicated Sprint, intensive versus standard lowering of blood pressure, and they had 35,000 people. So they actually showed a statistically significant reduction in incident dementia, and these are all Chinese. And they actually used what we used to call here barefoot doctors. It's really public health village officials to control the blood pressure. They didn't really, they're not medical doctors per se, and provided the medications to 32,000 Chinese people. That paper is under review. I'm one of the co-authors of that paper, but so that will answer a little bit more of your diversity question. And thank you for that question, really important.
There's another question in the chat. Do you have insights into post-Sprint whether PCPs or patients or both were unable to sustain tighter control? Was it prescribing or adherence or both issues?
Our anecdotal evidence is that patients didn't protest at all. It's just that the follow-up and and we didn't provide the medicines anymore, so people were restarted on different medication regimens, and were not started on the Sprint regimen, which was really start with 2 medications and then go up from there, and really start with either a diuretic or ACE, ARB, or a diuretic and a calcium channel blocker. And we found that many people, when they came off a sprint, they didn't use that playbook. So that's a big problem. I saw one question, maybe, I don't see all the questions, but I saw one pop up about why we didn't include nursing home. And really the hypothesis was from the very start, we wanted to study this in healthy ambulatory people of all ages. Nursing home is certainly an important population and a different population. Again, I think most of the nursing home population has an estimated life expectancy of less than 2 years. So while we didn't study them, you could see from the data that people who have a life expectancy of less than 2 years, intensive blood pressure control really is unlikely to have a benefit. I saw the comment too about, yes, there's a broad, everybody in Asia doesn't live in China. So I understand that. Yes, mainly I was just showing that we are expanding this work to different nationalities, especially at least this aspect of the Asian population. But I think blood pressure lowering should be expanded to all people groups.
Well, thank you very much, Dr. Williamson. It's a great talk, and obviously a lot of commentary and thoughts and questions, and really just a really wonderful, wonderful talk. So thank you so much for your time, and thank you everyone for joining today. We hope to see you next month at our next Pepper Center rounds in March. And thanks again, Dr. Williamson. Really appreciate it.
Sure, enjoyed it. Thank y'all for having me. See you. Have a great weekend.
You too.